Hello, everybody. This is an interview with Professor Abdelhadi Al-Khalili. He's a professor of neurosurgeon. He's one of the scientists in Iraq and one of the founder of neurosurgery in Iraq. So today we have multiple questions with Professor Khalili. We want to have his opinion, ideas, and answers about some of the interested questions. Today, we are welcoming you, Professor Khalili.
Thank you so much. It's really a great pleasure to be with you, Samar, and our young colleagues who will be the leaders in the future. And I'm sure they will be great leaders from what I can see and I hear and I know about them. Thank you.
Thank you. Thank you, Professor. And today with us, we have Sama. Yes.
Hello, everyone. Hi, Dr. Khalili. It's really nice meeting you today. I'm Samar Bermani, a final year medical student in Baghdad, and I'm interested in neurosurgery since my first year in college. And yeah, it's really a pleasure having you today with us.
Hello, everyone. Hello, Professor Khalili. My name is Hussein, a final year medical student at University of Baghdad. It's an honor to be here with you.
Thank you. Thank you. So today we will take different parts, me and Sama and Hussein, asking you, Professor, some questions, and I will start with the first few questions, then will be Sama will follow, and then Hussein. So let's start with the first question. Simply, we want to know why neurosurgery. Why you choose neurosurgery?
Well, in fact, I did not choose neurosurgery. Neurosurgery chosen me. Since my childhood, at the age of 11, I wanted always to be a doctor. And in my path to be a doctor, there were many hurdles. I don't want to go in details about those, but then I fulfilled my ambition to be a doctor and then graduated from the Baghdad Medical School in 1966, and then decided to be a surgeon. From my time of medicine and being in the fifth year, being in the theater, in the operating room, I had developed the desire to be a surgeon and decision to be a surgeon. Then you may know that we have compulsory service in Iraq to go to the countryside to serve the people in need there, and that will be for 1 year. During that year, the Ministry of Health publicized a request or an order to say that anybody who would like to go to ophthalmology or ENT, we can cut short his 1 year. And my ambition is to go abroad as quick as possible. So I consulted with my mentors in the medical school, Professor Khalid Al-Qassab and Suhair Al-Bahrani, and they said ophthalmology is surgery. And at that time, we did not have any highly qualified specialist in the country. No FRCS, no board, nobody there. So I trained in Iraq in ophthalmology, and then being ophthalmologist, so-called trainee or by apprenticeship. In Hilla, I was in Hilla as a ophthalmologist with a clinic. And then I went to England as soon as the opportunity helped me. I decided not to leave ophthalmology just like that. I trained in ophthalmology in UK maybe for a year or so, and then decided, no, that's the end of it, no ophthalmology. Because this is philosophical to myself, because I was dreaming of the relationship, the intimate relationship between the doctor and the patient, which I did not find in ophthalmology. That's on my feeling. Of course, ophthalmology is a great specialty. I thought this ophthalmologist is more as a scientist rather than a doctor dealing with the psyche. He deals with facts, cataract and floaters and the retina and the vitreous and retinal detachment and so on. So I had the opportunity to move to neurosurgery to try myself there, and I moved to in Scotland. When I was doing ophthalmology, there was an opening for opportunity for neurosurgery in Scotland, which I went there and I got the post, and I liked it very much and enjoyed staying there and remained there. Completed my training in Dundee, and then I went to Leeds to complete my training in there. I did not have any really relation with neurosurgery in the past, except 2 occasions. When I was resident in the Ramad Eye Hospital in Baghdad, we had a patient who was brought to the emergency with penetrating steel bars, the skewers bars, penetrating through his eye to the skull, to the brain. So there was edema and local problems in the eye and around the eye. And then the patient, while he was there, we are treating him, he developed epilepsy. So we knew, or I knew there is something beyond the eye problem. So we referred him to the neurosurgical hospital. The other occasion which I had with neurosurgery is when I was in Hilla, I diagnosed a patient with papilledema for the first time in my life. And then I thought that is a problem with the brain. So I referred that patient to Baghdad, to Neurosurgical Hospital. So I really enjoyed neurosurgery. And as I said, I started my training in Dundee, Scotland to start with, and then I got my fellowship of the Royal College of Surgeons, and then moved to Leeds. I'm proud to be trained by leaders of neurosurgery in the UK. The closest one to my heart, and I learned a lot from him, was Miles Gibson, who was a consultant at that time to the consultant neurosurgeon to the British Army, as well as his work in the university and at the hospital. And while I was in training in Leeds, I had the opportunity to go to Europe to start with Zurich. I worked with Professor Yagergil, who was at that time called the king of micro neurosurgery in Zurich. And I worked with him there. I attended a course which he runs once or twice a year. And also did some work with the other colleagues, a lot of research there on, for instance, the deep vein thrombosis in patients with long stay in neurosurgery. Compared that with Iraqi paper by Professor Mahdi Murtada, and they discovered that deep vein thrombosis in UK was more than what we have in Iraq at that time, compared to studies. And a few other studies I did there as well. But I did not want to be a professional person only, so I wanted to be academic, and I applied for postgraduate study as part-time for MPhil, Master of Philosophy of Science, to Bradford University, which I got in 1984. In fact, when I went to the examination, before the examination, my mentor, my supervisor, Professor Taylor, he said, well, your thesis is good for PhD. And then he presented that to the council of the university and approved it for PhD, and I sat the examination for PhD. And PhD is on the first page of my thesis. But they wanted some changes in the thesis. So I had to go back to Baghdad. At that time, the war of Iraq-Iran was there, and there was no way of going back to England. So I got the MPhil back, which I'm not worried about. When I went back to Iraq in 1976, I joined the team of 3 neurosurgeons in Iraq at that time. And then when I was in Iraq, I went training in Germany for brain lab and other things, and orbital surgery. And in Canada, did vascular surgery, and in UK did neuroophthalmology and also orbital surgery. And then Belgium, I did some work there with cancer. So in general, to answer your question again, in summary, as I said, I was chosen to go to neurosurgery, not dreaming at any time in the past to be a neurosurgeon. And I'm happy that I made that decision.
Thank you, Professor. That's interesting. And my question now, Professor Khalili, of the mentor you mentioned, is there any idol for you career-wise in neurosurgery? Looking for him as an example, as an idol?
Yeah. Well, my idol in the history, of course, was Victor Horsley. Sir Victor Horsley, who is the founder of modern neurosurgery, so-called. And he was somebody who unique in his CV, his achievements in life. He was the first to do tumor surgery, who was the first to do spinal surgery, who was the first to do epilepsy surgery, and many other things. And also he was social reformers. You may recall that at least in our time, when we were at the primary school, elementary school, we had once a year or twice a year a doctor and dentist coming to examine all the children, all the students. In fact, that was the work of Victor Horsley. He passed that law in England and then went all over the world. And he has many other. He was against smoking, against alcohol, and he was very active against these two things. And you may know, he died in Iraq when he came here in 1916, and then he was comatose with heat stroke because a doctor usually goes between the tents to visit the patients. And it was July at that time, and they are not they cannot be exposed to sunshine like we do. And then he had heat stroke, and then he died. The other mentor in neurosurgery was in the past was Walter Dandy. Walter Dandy is a genius, really. He's beyond imagination. Walter Dandy wrote a book, which is volume 12 on practice of surgery. And if you see the book, you would be amazed how knowledgeable that guy was and how innovative was that man. He invented the air encephalography. He also contributed a lot, maybe the first to know about the circulation of the CSF and many other things. Trigeminal neuralgia, he was the first to do the trigeminal neuralgia. And also I liked him most because he was the first to attack the orbit through the cranium. So in my orbital lectures, I always put him the first to be acknowledged. A very interesting picture he had in his book, which I have the book myself here. There was a shrapnel in the brain of a patient, and he could not get to that shrapnel except with using proctoscope. So I introduced proctoscope in the brain to get the shrapnel out. In my training, of course, I had real great neurosurgeons in Dundee, Ivan Jacobson and Mr. Block, and they were very, very helpful guys, were real friends. And then I used to visit with them when I go back to England after I left. But the mentor probably is the one who was Miles Gibson. Miles Gibson, we had very great relationship with him, and he used to call me Hadi boy. And even our correspondence, he doesn't say Hadi, he say Hadi boy, do that, this and that in writing. And he's a man with many talents. And for instance, he was a member of Leeds United Football Club. And we used to go to the VIP lounge in the stadium there with the heated seats in the middle of winter, because he was a member of the board, and he was also a member of the board of a steam engine train company in the area, which was very historical, and a few other things he has, this gentleman. And so these are the mentors in neurosurgery, but mentors in ophthalmology, I'll bring Mohsen Abu Turab to be the best I remember. Mehsen Abu Trab was probably to me was the best ophthalmologist at the time when we were at Ramad Hospital. Then he has only diploma, but in spite of his clinic was the best or the more active, crowded clinic, he left everything and he went back to England to do his fellowship. And then after 3 years, he came back with his fellowship. In general, my mentors, I would say that Khalid Al-Qassab and Zuhair Al-Bahrani and Khalid Naji were really the three giants. I follow their footsteps. But in the society in general, my idol was Professor Hussein Ali Mahfouz. Hussein Ali Mahfouz used to call me, I used to call him his spiritual father. Always, I went to his house and we met together, and I invited him many times to speak in conferences. One of them, when I held a cancer conference in Iraq in 2000, it was a big event there. You can see details in my memoir. And he talked about history of cancer in the Arab Islamic medicine. It was very rich talk at that time. So these are the main mentors in the fields of surgery, neurosurgery, and in general cultural life.
Interesting. Thank you, Professor. So, Professor Khalili, being in Iraq as a war-torn country, as a resource-limited setting, what's the impact that propose on your career in neurosurgery?
Well, as a medical student, we were lucky to have teachers of very high standard. In fact, some of them were British and Americans. For instance, Professor Haynes in anatomy, he was a leading professor, and he loves the students. Once I went to him asking him, "Sir, why do we get a sound when we click our fingers?" And he was just smiling and took me inside and told me that, well, I had research on that. I'm glad you asked this question. And then he told me about the mechanism. Why is that when the nitrogen will change from the soluble state to an air bubble, and then that sound will be there. So the teaching there was very high standard. Well, a good example of that, 12 of us went to the examination of ECFMG, the American medical license, in February, the year of our graduation. That's 4 months before our graduation. And 10 of us passed the clinical and the English test. And we were qualified to be licensed at that time in 1966 in February. So the buildup of knowledge, experience, and ethical standards at the medical school was as good as any renowned medical school in the region and in many developed countries. So we were fortunate to have that impact. In England, the impact was even more. But as you said, in a war-torn country, we had, which is unfortunate in a way, but that we had been involved in wars and violence for many decades. But during the Iraq-Iran war, all the surgeons, including neurosurgeons, and myself included, we developed really great experience in managing head trauma, because we've seen varieties of head trauma, multiple problems, complicated cases. Sometimes we work as a team, maxillofacial surgeon, thoracic surgeon, abdominal surgeon at the same time. So the impact on that really made most of us more experienced and also more courageous to go for these difficult cases. And that really was taken to when we went, all of us who went to outside to to UK or to the United States, we were there distinguished from the day one. Most of us, whoever you ask from our colleagues who went from that time to those countries and other countries, they will tell you that we were distinguished from day one because the experience and the knowledge and the training we had, really wonderful training. For instance, when I was in ophthalmology, I worked in Manchester Eye Hospital with Professor Phillips, who was the leading, the editor of British Journal of Ophthalmology. I stayed with him for 6 weeks, and after the end of the 6 weeks, he gave me a recommendation to be a registrar. He skipped me a stage of training in the UK, just jumped to registrar. So that was the impact, I think, as example of the impact of our training and our good upbringing in Iraq when we were there.
Okay, thank you, Professor. So, Professor Khalili, what's the impact of ophthalmology on your career in neurosurgery?
Well, let me say beforehand, I don't think there is any specialty better than other specialty. All of them are important, whatever you do. And if you are family physician, if you are neurosurgeon, cardiac surgeon, whatever. So there is no specialty better than specialty, or more difficult or less problematic than other specialty. Ophthalmology really helped me a great deal when I was working on the surgical side. When you do surgery in ophthalmology, you have to be very meticulous. And each movement, maybe in 1 millimeter of movement of your knife or your forceps can do a lot of harm or can do the real good you are aiming at. So the skill movement of the ophthalmic surgery has helped me a great deal in neurosurgery. And also when I trained in ophthalmology, I developed this interest in orbital surgery, which was really very interesting. And then I started, when I went back to Iraq, started the clinic of orbital surgery, which was the only clinic in the history of Iraq. Although the Professor Hussein Talib and Qahtan al-Rubi'i, they did some work, but a real clinic with patients coming with carding system was started, in fact, in the late 70s at Mustashfa Ibn al-Haytham, maybe early 80s, sorry. So then that was once a week, the clinic, and then I was dreaming of having this orbital surgery center, which after real hurdles and many problems, it was established in Mustashfa Agraha. And that was the only surgery center of the orbit in the country, and maybe in the region. But the WHO people, they came there, and then they wrote a recommendation letter that it is center of excellence in the whole region of and the Middle East and the East Mediterranean area. So ophthalmology made me really courageous to go to orbital tumors. So as a neurosurgeon, I can go to the orbital cavity through the cranium, but to go anteriorly to cut the conjunctiva to deal with the extraocular muscles is not something simple. I don't think a neurosurgeon who has not trained in that area can deal easily with that. To go to the optic nerve through the orbit is not an easy job, unless you have really training in ophthalmology, or you can get a colleague, ophthalmic colleague with you in the operating room to help you in that context. So ophthalmology really had a great impact on my first skill of surgery in general, and then on the orbital surgery and specifically.
That's interesting. Thank you, Professor. So Professor Khalili, prior to surgery, do you have a special routine, particular for specific surgery, or a special routine that you practice always? Anything?
Oh, yes, of course. In fact, I was what you call ritual in my work there, in the neurosurgical operation. I have to follow certain routines. What I say that one has to make sure of the medical records of the patient, because sometimes you have some mix-up of things. So, and make sure that all the images which you need are ready, not in the middle of the surgery and then you have something missing. This is really very, very unacceptable. And make sure that the consent of the patient is properly done and in the possible, or not the possible, the legal and ethical way. And make sure that all you need is available there, not in the middle of surgery and you have something, some complication happened and you don't have the tools to deal with that. For instance, when we had in the sanction time, our work was with the generator. So I did not do any elective surgery unless there is another standby generator ready in case this will go off. But of course, in emergency, this is different. You can work with the spotlight, with anything, if there's no electricity. And you must discuss the plan of surgery with your residents beforehand. So the resident will be aware of what you are going to do, what are your steps, and he may suggest something, or he may make your life easier during surgery by the way he assists you, and then you can work as a team. The anesthetist is important, of course, a member of the team, and you have to deal with the anesthetist in the best possible way and then give him the liberty of deciding whether you want to do the surgery, postpone surgery, do special maneuvers in surgery. So you have to respect the anesthetist and his opinion of the patient and your surgery. I usually start myself with the prayers during surgery, always. Just simple prayer. And then during surgery, what I really do and recommend to any surgeon, that to be completely disconnected with the outside world. Just think of the surgical field. Don't go anywhere outside the surgical field. You forget about family and work and life and everything. You concentrate there. So that's a very important thing, and then you can give all you know, all your time to the patient, patient's need during surgery. The other thing, you need to be a leader in surgery, in the theater. You have to be the master. Nobody will move or do something without your consent, and they should know your routine. So no rubbish things or unaccepted things in the theater. And then when you finish the difficult part of surgery, you have to relax and then make some connection with the staff there, some jokes, something to ease the tension which they had during surgery, with the especially difficult surgeries. So these are really the most important things I would think of surgery. And then also when you finish the surgery, it is still your responsibility to take care of the patient. You must make sure that everything is okay. You stay with the patient until he recovers. And then at night, you have to call. In fact, when I did my private surgery, the anesthetist, he stays overnight, all the night. He will be the nurse to observe the patient's progress. And in the morning, he gives me a report, and then he leaves if I say yes. So it is your responsibility from the time you put the knife there, or when you decide to do a surgery, and then until the patient is, you are happy with his condition after surgery. I think these are the most important things come to my mind at the moment.
Okay, that's interesting. For things related to pre-surgery or even as a post-surgical period. Professor Khalili, if I say for a surgeon, surgical skills, publications, mentoring, and institutional leadership, how you put them in a priority, and in general, why?
Well, I put skill first, because when you are a skilled surgeon, you get respect of all the team, all the people around you. And if you are not skilled, then you lose the leadership power and situation. So you need really to be skilled. You have to have a good experience, and they know that you are experienced and you can deal with complications when they happen, and then you get the respect of all. Regarding leadership, or maybe we'll start with publication. Publication is a must if you are in educational institution. If you want to be a professional neurosurgeon, that's great. You don't need to publish, you just do your work, you perfect your work, you improve your work technically, and you don't need to publish if that's what you like. But being an ambitious person or working in an educational institution, you must publish. And the publication has lots of rules and means of doing it properly. You cannot just publish whatever comes to your mind. And publication has to be honest, has to be transparent, has to be useful, has to be peer-reviewed. And the more you publicize, you public is the better. But we don't follow the rule of publish or perish, because our life is not like only publication. We have the profession, we have the patient to deal with. So publication is an addition, is a great addition to the profession as a neurosurgeon. And mentoring, you have to be a good mentor to your colleagues, to your young colleagues. You have to be a good example to them, care about them, and look after them, and give them all you know. Because this is a must, because as a teacher, you have the responsibility of teaching your students to the best of your knowledge. I always say to my juniors that I would like you to be better than me. And I work for that. Otherwise, if you will be like me, or maybe less, or a little more, or better, the profession and society will not progress. So you need to be better than me, and I help you to be better than me. And I started, in fact, the promotion for subspecialty at that time. I asked, for instance, one of our young colleagues to be pediatric work mostly, and the other for peripheral nerve mostly, the other for spinal. Although it did not materialize, but at least I implanted that seed in their minds. Institutional leadership, you have to be a good leader. A good leader will be not a dictator, but he has to be firm, he has to have strategy, and he has to also follow that strategy, not put strategy and then not follow it strictly, and also care for your staff. You have to care for your doctors, even your nurses, and the people the cleaners and the technicians, everybody. And to get their respect and their teamwork spirit, you have to make sure that they are happy. And if they have problems, they will come to you to solve their personal problems. If they have occasions of happiness, celebration, you join them. And then, in fact, you may know that I did every 2 months, 3 months, we have together everybody there in the department to have a meal and fun and talk, and everybody from consultants to the cleaners, all of them. And I have a video on that. So that will ensure that you are really a good leader, and you can succeed in your task of your institution.
The priority for the four, what will be? What do you think?
I will put skills first. If you are not skilled, you cannot be a leader. And then they come later on, these things. They all are very, very important. But as you said, priority is that you will be competent, you will be able, you are experienced, and then you can lead everybody. If you are not experienced, nobody will respect you. Once or twice you make problems, and then they will turn their heads away from you.
Thank you very much, sir.
Hi again, Dr. Khalili. My first question would be how your family cope with your career, or in general, what's the impact of having a neurosurgeon in the family?
Well, there was a saying that a wife of a neurosurgeon is a widow, and although her husband is somewhere operating, that was saying of a British neurosurgeon. Well, I was blessed to have a wonderful wife, very understanding, very wise, very helpful. She's a qualified librarian, and she was in charge of research center at Baghdad University, and she had some publications, and she took care of our 3 children. I sometimes work literally about 18 hours a day in different places. So she was alone at home, and she was doing all the tasks of housewife and the mother and the housekeeper. In fact, after our marriage, in the first few months, I was doing research on third nerve injury on rabbits, and I had to go to the medical school in the afternoon. And so instead of me taking her by my car from the office to home, she goes by taxi to give me the time to do my research. So that was really very, very helpful. And she was supportive. And also she supported me in my writings. All my books in Arabic and English, because she graduated from English literature BA she had, and then she was qualified librarian. She helped me in the structure of the Arabic language by Arabic publication and books, and also in the English literature, which I wrote, and very helpful and very supportive, and good ideas she gave me. Sometimes she criticized my points and I changed according to her decision and suggestion, and sometimes she doesn't. So she was very, very helpful, and my children were very helpful. And then with her hard work and with my support, the children were grown up, and then 2 of them are now consultants, attendings, and the staff member of the University of Georgetown here in Washington, 1 neurologist and 1 radiologist with the breast imaging, and both are doing well.
That's amazing, actually. Okay, Professor Khalili, I also wanted to ask about 3 challenging situations in your career and in your surgery in general that has impact on your career.
Well, the 3 of them are important, not with different maybe level. The first one was when I was in 3rd year in the intermediate school, that's the 9th grade. As I was telling before that I dreamed of being a doctor in the future. I failed in the final exam the 3rd year, and I had to go to the commercial side. And then I was upset because I wanted to be a doctor. What does it mean to go to commercial, to be accountant or something? Although no profession is better than other profession, all are important in life. So nevertheless, I worked hard, and then I was exempted from the final exam. I was one of the top students there, and then I went back to the 3rd year final exam, and then had the exam, and then succeeded in that, and then took the path of my medical dream. The other impact was when I decided to be a neurosurgeon, because I was really confused when I did not want to stay in ophthalmology. And then I received a letter from Professor Zuhair al-Bahrani, who is my mentor and close friend. And the letter was of Razala. He was very much upset with me and said, "It is you who was the first top graduate who were dreaming that you would be one of the good people to contribute to medical services in Iraq. You don't know what to do." So then that really triggered me to do something, and then I moved to neurosurgery. And that letter, which I still keep, I cherish really. Although it was Razala, it was reprimanded, but I liked very much. The third one, of course, is my kidnapping. I built up what I call it's a pyramid of services in Iraq, in neurosurgery, in our hospital, and also in orbital surgery. But it's unfortunate that when I was kidnapped in 2004 and I forced to leave the country, I was very, very sad to leave the country. And then that was a great impact on my life. And then they offered me to be a Minister of Health a few times, but I excused myself and then they apologized. But then I was offered to be the cultural attaché to deal with health and education links between Iraq and USA. And then I liked that, and I stayed there for 7 years, and I did many things in that time. So these are the main three impacts in my life cycle, if you want.
It's really wonderful that the first one started in medical school. It also has an effect on the neurosurgery path. It's really impressive.
Yeah.
Yeah. Okay, Professor Al-Khalili, my next question is about your publications. Can you tell me what's the closest publication to your heart, the favorite one, or ones?
Yeah. The closest one to my heart was, in fact, the research which I did on hydatid cyst pictured images in the orbit, because I was really upset and not happy when I opened the cranium and opened the orbital roof to go for this so-called brain tumor, as the CT scan was telling me, not brain tumor, sorry, orbital tumor, as the CT scan was stating, and I found it is hydatid cyst and could have been done without opening the head. So that was really upsetting. And then I thought, why is that? So I thought of three possibilities. Either the pressure inside the cyst is too much for the CT scan to show as a tumor, or the nature of the hydatid cyst is different in the orbit from other places. It is thicker, maybe the fluid or something. Or it is physics, because the change from the bone with high density to fat, which is the lowest density, immediately the sudden change will confuse the computer of the CT scan to interpret it wrongly. So I was thinking of what can I do? So I asked Amu Baba, Allah yarhamah, the leading, you know him, the sports guy, leader of sports and soccer in Iraq, and he's a friend, and told him, can I have an old football which is made of leather on the outside and rubber ball inside, and we have to put air in it. And I was thinking of pushing more air to increase the pressure, and then the balloon will accommodate, because the leather out the outside will not expand, and it accommodates higher pressure. I couldn't get that, unfortunately. Couldn't find it at that time because it's very old. So then I thought of taking a glove and then put water in it, ordinary tap water, and then amputate 2 fingers and put them one in the orbit and of the skull, and one in the cranium, and put some slices of fat in the orbit to simulate orbital fat. And I was fortunate at that time, we had an Irish engineer of CT scan, very good guy, Michael, and we used to go at night there to do the work. because if we do daytime, nobody will accept that, and then they'll say you're taking patients' time and so forth. And then we destroy all the negatives at that time. And then prove that the third theory of changing the density, because the water is the same in the cranium and the orbit, and the pressure is the same atmospheric pressure. But when we did CT scan on both in the same picture, we found that the CT level or density of the orbital cyst, the glove, 5 to 7 times denser than that of the cranium. So that was really, I really enjoy. And then when I sent it to USA, to American Journal of Computerized Radiology, it was accepted without any modification, just as is, and immediately was published. The other one, of course, you said more than one perhaps, the spinal cord grafting. When I was in training for orbital surgery in Germany, stayed there for 3 months, I was going to the lab always there, and the cadavers, and they used to open the skull, and then Samr is doing it now in a better way, of course, more elaborate, doing this cadaveric work. So in there I did work, and then I saw people around me doing other works. For instance, the first knee transplant was done on cats at that time in the laboratory next to me. So at that time I was thinking of third nerve grafting, or third nerve injury, not grafting, sorry, third nerve injury. Why? The third nerve, when it regenerates, it will go aberrant regeneration. It goes to, the nerve fibers go to different muscles. So the patient, when he closes his eye, the normal side, the other affected side the lid will open, and the eye will go to the lateral, for instance, or something different. So when I came back with a friend of mine, Mohammed Hayawi, the head of anatomy department, then we did work on rabbits. And this is a very important story, I think, to listen to. We did the rabbit. Rabbit is a very bad animal for experimentation. If you give higher anesthesia, the animal will die. If you get light anesthesia, it will jump during surgery. So the range of anesthesia is very, very narrow. And we did the work. It was wonderful work. In fact, I got the approval of the project with a neuroscientist in England, and the approval of studying the histopathology by a professor of histopathology in Germany. So it was very high standard work. And then at the end of the work of 1 year, we came to the animal house at the medical school in Baghdad. And then we found that the guy, the attendant of the animal house, had distributed all our rabbits to different places, and all the project collapsed. We could not proceed. So I was just smiling. This is Iraq, and we have to accept it. So we started spinal cord grafting again. And spinal cord grafting was something interesting, and we did it on mice. And then the work was published, experimental again, on animal only. Published in the Journal of Spine in the UK, was the spine, the leading spinal journal in the world. So these two research projects were really to my liking, and I remember them well because they were really after hard work.
And what's the story behind Imam Ali paper?
The story behind Imam Ali, I was invited to the White Palace, not the White House, the White Palace in Baghdad, Qasr al-Abyad, where there were people called themselves al-Ruwad, with Professor, for instance, Kamal Samarra'i, Professor Musari al-Rawi, Professor Hamid al-Hiti, who was the Dean of College of Art, who invited me there to speak about something. I chose the topic of neurosurgery and society. That was my talk, a detailed talk. And one of the things which I touched on was head injury. And I quoted 3 people in my mind were interesting to think about, were Imam Ali alayhi salam, and King Ghazi, and Ivan the Terrible. Ivan the Terrible, who killed his son by head injury, and then the story is in details. So King Ghazi, I worked and I have now worked about 70 pages on King Ghazi's death in details, but I did not publish that. But Imam Ali really made me think, what was the mechanism of death? Why did he die? Because we know that he was hit by a poisoned sword. So was his death because of the head injury or because of the poison? Or was it combined? So I digged into the literature and I got very, very great support from Najaf about all these history books. They got me the pages related to this incident. And also I went to literature outside and then studied the poisons at that time, including the poison of Socrates, who was given this poison to die with it, and then the effect of that, Socrates. And then I studied that in details, and then looked at the injury itself. Where is the injury? How the injury was done? And then postulated that the injury was on the left side paramedian, on the junction between the forehead and the hair of the skull. And on studying the poisons, I found that none of the poisons was fit to explain why did he die. Because all the poisons will make the patient unconscious before they die, while he was conscious to the last moment. Regarding the injury itself, the head injury itself, there is the doctor who was called the doctor of chair at that time, صاحب كرسي, اللي هو أثير السكوني. أثير السكوني was the best of 150 doctors at that time were in the area, surprisingly. And he came to examine him, and then he found that there is a gap, and then he asked for a lung of a recently slaughtered cow. And he got that, and he got small bronchiole from the lung, which is tough and like a tube. Although in the literature say عرق means maybe artery or vein, which I disregard that. And my theory is it is a bronchiole, and he introduced it inside the head, and he got the white matter. And the white matter was white. And then he told him that this is the end of you, sir. So when the white matter was white, that means there is no intracerebral bleed. And there was no infection around the wound, so there is no infection. There is no evidence of encephalitis or transmission of infection to the inside. So then he did not have any neurological problem. He was not epileptic. So many details maybe in my work you can guide him to. So then I discovered that I explored all possibilities of why did he die, all the options, all the possibilities. I could not find any solution to my question. I left it open to other researchers.
Well, that's really thoughtful. Need some moments. Okay. So the next question will be about the surgeries. I mean, in general, what's the best and the worst surgeries regarding maybe complications or outcomes in general?
I cannot say that I have worst surgery because I did, depending on what one means by worst surgery or best surgery, because I'm sure every surgeon does his best to do whatever he can to help the patient. But worst surgery with surgery which will end up in complications. But otherwise, there is no worse surgery. We had during the wartime, we had very, very difficult cases, and then massive problems. We have one of the patients, for instance, I operated on with a severe injury to the head, and he required 22 pints of blood, imagine, because he was bleeding like hell. So that the word worst surgery, I don't know how I can specify that, but good surgery, the best surgery is always you are work for the best surgery. But I remember things, for instance, we didn't have any endoscope, neuroendoscope at the time, and we didn't hear of an endoscope. So I had a patient who has the third ventricular tumor, and then with hydrocephalus, and I don't know what to do with him. How can I reach a conclusion? It was solid tumor. So I asked my colleague, the urologist, and then we got a pediatric ureteroscope. And we passed that to the ventricle, and we got a biopsy through this so-called endoscope. Using the microscope during surgery was something really, it was a blessing at that time. You see, at time of Hisar, you cannot dream of that, but I tried my best to different places to get this microscope and then use that. And also I've done, there is a unit in the Aggeraha hospital where there is a connection of the theaters, of all theaters, to have recorded the operation in that unit on the second floor. And I was in charge of that unit. So I really helped other colleagues to record their surgeries. So back to the question, as I said, best surgery is always you work for best surgery, and worst surgery, you don't dream of having worst surgery, but the complication can make your surgery worse, as you said.
All right, great. And my last question for here, Professor Al-Khalili, it's also for the surgeries in general. Can you mention the best surgical team, including the best assistant surgeon, the best assistant resident, anesthetist, and nurse of all times?
Sure. My surgical team, the best were, I think, 3 people I remember well, although many of them are very good and they are close to my heart. But the 3 of them I remember, Ali Shalchi and Ari Sami and Qais Shamal. I remember them really all the time, although, as I said, I remember others as good. In the operating room, we had head of the operating nurses or technicians or dressers, as we call Hisham. Hisham was a wonderful guy. He's intellectual. He's a writer, and he's dedicated to like religious dedication, really, in the theater. Very clean, very meticulous. Everything has to be done properly. And also his assistant, Rahim al-Rashidi, was another wonderful guy who is the chief dresser there, and just to bring us in charge of sterilization and things like that. And he was, I remember him very well. And in fact, I have communication with them, even up till now. We communicate. In the ward, we have Marta Isa. Marta was the head nurse, was first-class nurse, very dedicated, very experienced. And also I had Salam Shuwaili. Salam Shuwaili was a wonderful guy again. We had at that time about 13 or 14 young dressers or nurses, as we call them. And they came, they don't know what is the atmosphere of the hospital, of the department, and they were laughing and shouting and things. I brought them in to my room. And then by the end of the training, when they say good morning to you, they bow to you. They were so well-mannered. And I made the department of neurosurgery a department of temptation to all these dressers and nurses. Although the nursing of our patient is very, very difficult compared, for instance, into eye nursing. put drops and that's it, and the follow-up. But here you have so many problems, but yet the people, they were competing to come to join the neurosurgical department. In the surgical team, we have Najat Yusuf, who was in charge of the theater operating room as operating nurse, and Jinan Abdul Amir and Saad Thatcher. When Najat retired, I made a very big event for her with the meals, and then I invited the head of the hospital, the head of medical city, all of it, and present her with a gift to make a lesson to other people that when they retire, they will be kept respected until the last moment of their work. The others, the anesthesia, and Mazen Jafar. Mazen and Dhaka Abdul Hussein and Leila Khalil. Mazen was a unique person. Nobody liked Mazen. Mazen, a wonderful guy. He shouts, he's noisy, but he is very clever. And imagine that during his nighttime, he went for BA in history, and he completed that. And then he went to, after that, BA in Hebrew language, and he did that. And also we have Makki, who was the chief technician, Makki Mustafa, chief technician of nurses. So these are in radiology, of course, we had Muhammad Hassan al-Ishaq, he was there helping us a great deal. So these are the names which who I can recall now.
Okay. All right, that's great, really. A lot of names here. I think Hussein can take over the rest of the questions. Yes.
Okay, thank you. Hello, everyone. Hello, Professor Khalili. My name is Hussein, a medical student at the University of Baghdad. I will complete this part of the interview. So, Professor Khalili, what are the best advices you get from your mentors, especially in the field of neurosurgery?
Yeah, I got lots of advices. Well, mostly from Professor Miles Gibson. He used to tell me that if you want something to be done, ask a busy man to do it. Because a busy man is a man who can, use your request, something to be done between his busy schedule, and then he can manage it. But the person who is not busy, who will postpone this, well, I'll do it tomorrow or do it next week, and then he will possibly forget about it or not do it properly in the right time. The other saying he used to say that nobody is useless. Even the bad one can set a good example. He's worse than that or better than that. I think he can be an example to compare the goodness or the badness with that bad person. So he's not useless. Anybody can be useful, even the bad one. But in general, I had, for instance, do not underestimate a piece of information your resident gives you or your colleagues give you. They may be right in their decision. So don't be very much thinking that you are right always. Listen to other people. These are I think the main thing which I got from my mentors. But there are things which I have myself. If that's if you want to know about that.
Yes, please. This is the next question in my list. Professor Khalili, we want to know what's your advice for residents and young neurosurgeons.
Well, neurosurgeon is not really different from other residents. The basic advice to all is the same, but I will start from the basis. I think you need to learn about history of your specialty. You have to link between what the giant has done in the past and in the late 19th century and 20th century to give you on a tray of gold their knowledge, and then you build on that. So you need really to learn something about the history of your specialty. And as I said before, that the surgeon, excuse me, the experienced surgeon is the one who can decide what not to operate, when not to operate, not the one who will decide immediately to operate. That's very expected, of course. When you see the problem, you operate. If you see, for instance, brain abscess, shall I remove this abscess, go ahead with radical surgery, or shall I drain? If you see subdural hematoma, shall I wait and evaluate this patient or wait? Has he got some problems, some neurological problems, which even not very big subdural hematoma needs evacuation because he has neurological complication? Or it's rather a bigger hematoma with no complication, with no neurological problems. So you need really to be able to decide when not to operate. The other thing is, as I said before, when you are in the operating room, you must really disconnect yourself from anything in the world completely. And you have to do your best and that. And never estimate an opinion of a junior colleague, because a junior colleague, when you discuss with them, they may raise a point which is very important for your work. You need really to do everything you can to help your patient during surgery and treatment in general, which means that you should never ever think of your patients when you go to bed that if I have done this would have been better, why did I miss this thing? So you do all the best you can to help the patient, where you cannot, you will not blame yourself for doing something wrong or not doing something. And also remember that there are 2 committees overseeing you. And the committee is the legal committee in the hospital or in the country, and the other legal committee is up with God. So you do the thing which you believe in, and you have to do the best again which you believe in to help the patient. When one friend, when a colleague consults you, that's, as I said, is a pride that he's respecting your wisdom and your opinion. And so you have to be thankful to that person, that colleague, and be good to your staff, especially when you are at night doing your night work. You need to make sure that they are respected. You help them. You understand their problems. Don't be like the master of the show. And so they can do willingly, and they can help you in looking after the patient. Other things, you need to improve your knowledge. Continue with reading up-to-date information, and improve your surgical skills. And if you are with one mentor, you need to move to another one to see maybe the same problem but dealt with by that other mentor differently. So, and then you can choose one of each, and then you can develop your own procedure later on in the future. So basically, these are the main things which come to my mind now as advice to the young neurosurgeons.
Thank you so much, sir, for sharing your experience with us. My next question is Professor Khalili. We want to know if you were not a neurosurgeon, what you will choose as a career?
Well, you might be surprised. I was well, hoping, if not a neurosurgeon or not a physician in general, I would have been medical legal pathologist, because I really like the challenge of getting into mysteries, trying to find the truth from bits and pieces from here and there. So medical legal pathologist was really very, very interesting to me, and to find out what is behind the events. In England, it may be funny to say that, because when I saw the policeman, I was thinking, why not a policeman? Because again, policeman is a man who helped the society, and he looks for causes of disruption of the society, try to help and try to support the society. So only these two were then crossing my mind, but of course, neurosurgery was on the top of all.
Okay, that's very interesting. Professor Khalili, could you share 3 interesting situations, whether it's awkward or funny, in your career in the field of neurosurgery?
Well, I recall three interesting events which I remember clearly. One, in the Iraqi-Iran war, I was operating on a young guy, a young person, with the shrapnel went through his frontal lobe on one side. He was normal neurologically and fully conscious, nothing there. So we took him to theater, made everything required, the bleed mouth, the skull, skin, and the brain damaged and everything. And then before I finished and come out of surgery, I saw a small piece of bone, maybe 1 millimeter by 5 millimeters, 6 millimeter, deep inside the field. So I thought, we have to take this out. I'm not going to leave this inside. So when I took it out, well, there was a jet of blood coming, maybe 1 meter or more from that area. So apparently that went through the anterior cerebral artery, and then maybe middle cerebral, I was not sure, but in that area. And then when we took the bone, the opening there, leaking the blood in a very, very nasty jet. Now, in the war field, you don't have anything there. And your patient is fully normal, and he will definitely die if you don't do anything to him. We don't have any clip. We don't have anything really to stop the bleeding. So what I did is immediately got 2 suckers in there, and then got piece of periosteum and push it there, and then cotton wool ball, wet, soaked with saline, cotton wool ball pushed inside to keep that piece on the artery, and then stuffed all the surgical field with cotton wool balls, maybe 6 or 7 or 8 ones. And then everything was okay. The bleeding stopped, and no soaking of these cotton wool balls. And then closed the dura and came out. And the guy, after surgery, was fully conscious and nothing there, and laughing and happy, and he doesn't know that he has problems in his head. So in 24 hours later, we removed the cotton wool balls gently, quietly, and everything was fine and no bleeding. And that was a case to remember, really. You need to to improvise something in these difficult situations where you have life and death situation. So that was a case which I don't forget. The other one, a VIP person that was brought from the north of the country. So VIP, who sustained severe head injury, was comatose. He was so VIP, as I said, that chief anesthetist came with him in the ambulance and bag him all the time until he reached to our hospital. And I was on duty that night when he arrived. And then I sat in front of him, and he was fully, completely comatose, no response, no spontaneous respiration. So I said, why don't we do a CT scan for this guy? We don't know what's going on. And when we did CT scan, there was a huge intracerebral hematoma. And then I said, well, if we have seen the hematoma, why don't we go in? So I decided to go in and evacuated the hematoma, which was hugely, very, very big one, lacerated the brain in the area. And then everything was okay with surgical-wise. And then after a day or two, he started to move. And then he gradually improved. And then that guy, he left the hospital walking on a cane, on a stick. And then he lived for 9 years after that. So that was another case, what a lesson to us, that you don't give up hope if there is any way of helping the patient. The third one was in England. You may not have heard of this, called the Yorkshire Ripper, a criminal who killed 14 ladies in the 70s. And he created a real mess in the society there. And the ladies, they have to have a whistle in their purse, in their handbag, to whistle if there is any problem and somebody suspicious and things like that. So this guy, Peter Sutcliffe, he usually uses a hammer and hits the back of the head of the ladies, of women at night, middle of the night. So they brought one victim of this criminal, again unconscious, with the severe damage of the occipital lobe and the occipital area of the bone and things, fractures, depressed fracture fragments. And I operated on her, and then she survived. And she was the only survival of the 14 victims of Peter Sutcliffe. And then later on, maybe 6 or 7 years later, when I was in England in the trip, the police came to take me, and then I have done something wrong because they don't know anybody. Nobody knows that I am here, but the police, they know everything about everybody. So they came and then asked me to appear in the court. So when I went there to the hospital to get the case notes, I found that in my case notes, in my operating notes, I've written all the details, including the scratch. I described the ecchymosis, the round ecchymosis on the head, on the skin, in details. And they accepted that as a witness without going to the court. And then they thanked me for that. And I was I thought, I was fearful that I was really accused of something, but then it was something good. So, and you can see that in Wikipedia, in fact, when you Google, when you see Peter Sutcliffe, and you can see that my name is there in the Wikipedia as a reference and there. So these 3 events I remember very well. And then the message is, don't give up, and especially in cases of injury, of trauma, and then do the best you can, and work very hard to repair the damage which happened.
What a great story. Thank you, Professor Khalili. Professor Khalili, could you mention 10 people you want to thank?
Well, it's a long list of people I would like to thank. Of course, we start with my father, who implanted in me unmatched spiritual bond between the patient and the physician. And of course, my wife comes at the top of the list for her support, wisdom, and love and care for the family. My teacher of chemistry at the high school in Najaf, Dr. Ibrahim Fadli, who was a good mentor, and he taught me a lot of determination. He left everything and he went to do PhD abroad, and then he was a good mentor. Professor Tariq al-Hilali in physiology at medical school, who taught me to do things now and do not do something else tomorrow. Don't postpone things now. Which an example that blood pressure, we used to take blood pressure training in the second year. So I told him, sir, we are going to go to the world and then we learn there how to do blood pressure. And he said, well, learn blood pressure taking now and then learn something else in the future. Of course, Professor Khalid Al-Qassab, he was people I would like to thank because he was a friend since we were students, and then until I was with him until he died, God bless his soul, in Jordan, and I was really very much attached to him. I remember, of course, Zuhair Bahrani is the same, a real friend and good mentor. I remember when we were stagiaires last year, final year in medical school, when we finished our training in general surgery, usually Professor Khalid Al-Qassab gets Professor Zuhair Al-Bahrani and Professor Abdul Karim Al-Khatib, who were in charge of the unit, and then all the students there without the residents to find out what's going on, what's happened. So everybody said something, and what I said, well, we learned in this unit not only surgery and medicine, but we learned ethics and how to deal with the patient, with the bedside manners. But there's something I would like to tell you. The rate of preventable death in your unit is very high. And they were shocked to hear this from me. So I gave them example of what had happened with some of my patients and other patients. And the reason was the chief resident was an ignorant person. And then on that, after that meeting, he was dismissed from the unit completely. The other person I would like to thank, Professor Khalid Naji, who's a great mentor, one of the best diagnosticians and innovator. And Professor Khalid Naji, in fact, lately in the 2003, I operated on him with a big subdural hematoma, which was inflicted after being assaulted, unfortunately, by criminals. Ali Ghalib Yassin was professor of anatomy. He was a great mentor. I remember him and have lots of story about him. And then Dr. Professor Mahmoud Hayawi, who was the head of anatomy department at medical school, and then became dean of medical school and then head of the university, and was one first-class researcher and philosopher. Akram Uthman, he was the head of the Iraqi Computer Society and Informatics. And again, he's a great man, with a real philosopher and far-looking. And then he mentored many guys, students, and young people in computer field. So, as I said, there are many with anybody else. They have many people in their lives, but these are the main people who come to my mind now.
Thank you, Professor.